Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 523 of our pharmacotherapy series, which majors in renal dialysis. This case refers to patient ROW discussed in parts 520, 521 and 522 of this pharmacotherapy series. My next question to you reads: what other hemodialysis-related complications must be watched for and how can they be treated? We will now look at muscle cramps. Perhaps also related to fluid shifts, muscle cramps experienced during dialysis may be induced by excessive ultrafiltration, resulting in altered perfusion of the affected tissues. Several treatments have been attempted, including reduced ultrafiltration and infusion of hypertonic saline or glucose in non-diabetic patients, for cramps occurring near the end of dialysis. Exercise and stretching of the affected limbs may also be beneficial. Short-term daily administration of vitamin E 400 international units alone or in combination with vitamin C has been found to reduce episodes of cramping. Vitamin E can cause bleeding and potentiate bleeding with warfarin. Vitamin C therapy is known to produce hyperoxaluria, oxalate-containing urinary stones, and renal damage. Therefore, vitamin C supplementation is limited to 60 to 100 mg daily. The long-term effects of vitamin E and vitamin C administration in hemodialysis patients are unknown. I will now briefly talk about dialysis disequilibrium. Dialysis disequilibrium is a syndrome that has been recognized since the initiation of hemodialysis more than 30 years ago. Its etiology is related to cerebral edema, and patients new to hemodialysis are at a greater risk because of the accumulation of urea. Rapid removal of urea from the extracellular space lowers plasma osmolality, thereby leading to a shift of free water into the brain. Lowering of intracellular pH, as can occur during dialysis, has also been suggested as a cause. Clinical manifestations occur during or shortly after dialysis and include central nervous system effects, such as headache, nausea, altered vision, and in some cases, seizures and coma. Treatment is aimed at prevention by initiating dialysis gradually by using shorter treatment times at lower blood flow rates in new patients. Direct therapy can be provided in the form of IV hypertonic saline or mannitol. I will now briefly talk about thrombosis. Dialysis access loss is most often the result of thrombosis, which is usually a consequence of venous stenosis. Prospective monitoring of access function, e.g., intra-access flow, static or dynamic venous pressures, measurement of access recirculation, and physical findings, such as swelling of the arm, clotting of the graft, prolonged bleeding after needle removal, or altered character of the pulse or thrill, is paramount to the prevention of thrombosis. Fistula patency generally is much greater than synthetic graft patency, although thrombosis and loss of function may occur in both. The stenosis may be corrected by percutaneous transluminal angioplasty or, if necessary, surgical revision of the access site. Successful correction is effective as a means to prevent thrombosis. Once it occurs, thrombosis is managed by surgical or mechanical thrombectomy, or use of thrombolytic agents. Alteplase, reteplase, and tenecteplase appear to be effective for thrombolysis of the vascular access site. Thrombolytic therapy should be avoided in those patients with an increased risk of bleeding. For patients who have tunneled, cuffed hemodialysis catheters for hemodialysis, the success rates for clearing occlusions was greatest with reteplase at 88% ±4%, then alteplase at 81% ±37%, and tenecteplase at 41% ±5%, with no serious adverse bleeding events reported for thrombolytic therapy. Catheter locking regimens of heparin 3 times per week or recombinant tissue plasminogen activator instead of heparin at the midweek hemodialysis session was found to reduce the incidence of catheter malfunction and bacteremia. The next question reads: do oral anticoagulants or antiplatelet agents have a role in preventing clots in ROW's hemodialysis access site? The correct response is: anticoagulants and antiplatelet agents have been evaluated in the prevention of graft thrombosis. A large, multi-center, randomized, placebo-controlled trial found a modest effect of extended-release dipyridamole and low-dose aspirin in reducing hemodialysis graft stenosis during the period immediately after graft placement, and improving patency duration by 6 weeks. However, approximately 3/4 of patients had loss of graft patency at 1 year. Bleeding occurred at a similar rate, that is 12%, in the treatment and placebo groups. In a cost-utility analysis, aspirin alone was found to be the most cost-effective approach, but no prospective studies have evaluated aspirin alone in preventing graft thrombosis. In 2 separate randomized, placebo-controlled trials, therapy with low-dose warfarin to achieve a target international normalized ratio of 1.4 to 1.9 or combination therapy with clopidogrel and aspirin in patients with polytetrafluoroethylene grafts showed no benefit in the prevention of thrombosis or prolongation of graft survival. In both studies, patients receiving active treatment experienced a significantly increased risk of bleeding. A small single-center, randomized, placebo-controlled clinical trial found that fish oil reduced graft thrombosis. However, this benefit was not borne out in a larger, multi-center, randomized, controlled trial. Based on these studies, oral anticoagulants or antiplatelet agents have no defined role for prophylaxis of graft thrombosis. Assessment of the hemodialysis access site is performed at every treatment to identify any signs and symptoms of an access infection. My next question to you reads: should ROW be given prophylactic antibiotics, e.g., cefazolin with each dialysis, to avoid infection of his hemodialysis access site? Explain your rationale. The correct response is: access infections, usually involving grafts to a greater extent than a native fistula, are predominantly caused by Staphylococcus aureus or Staphylococcus epidermidis. Infections with gram-negative organisms as well as Enterococcus species occur with a lower frequency. Access infections can lead to bacteremia and sepsis with or without local signs of infection. There is no evidence that prophylactic antibiotics are of value. To the contrary, indiscriminate use of antibiotics could lead to colonization with resistant organisms. Thus, ROW should not receive a prophylactic antibiotic. However, if evidence of infection is present, a prompt response is important. KDOQI Clinical Practice Guidelines for Vascular Access also advocate surgical incision and resection of infected grafts. Fistula infections are rare and should be treated as subacute bacterial endocarditis with 6 weeks of antibiotic therapy. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 524.